therapists and people who work directly with the kids, because I always, during my talks, get the looks eventually, and that's so reinforcing. The other fun thing, of course, is talking with parents with the kids and having them do moments. So I guess I live for those moments. All right. So are you guys, tell me who the group mostly is. What kind of group?
It's a mix, kind of case supervisors, so they're managing X amount of cases in field, some therapy, some speech.
Okay, so I've got a mix of case supervisors or case managers and I don't want to go up and down. Therapists, a lot of folks that are directly involved with the kids, right? And again, I'm in private practice. I had 10 years at Kaiser Permanente in Southern California, and I was the director of Southern California Kaiser Peds Neuro. And so that was like 20 years of experience. So now I'm in private practice so that I can give a different level of care. And let's move on to what's fun for me. So, no, what's fun for all of us, right? So I wanted to go over seizures, epilepsy, detection, and diagnosis, as well as the why bother, and what the future looks like for these kids. Does that sound about right? One more. Immediate response. So, one of the fun things I always do when I show up is look at the person who's asked me to talk and go, was I supposed to have a talk ready? And so I already tried that once. It's already like a bum joke, so now we know this was sort of where I was going. But are there things that you guys think, boy, you're missing one of the topics I need to know, or do you want me to just get started? And then I want you guys to know you can raise your hand. If the people that are on the webcast,
they'll be able to ask questions.
Perfect. So feel free to let me know. So let's start with the immediate response to a seizure. And what most people are going to be thinking about is a convulsion. Of course, I'm going to talk about how there's also other kinds of seizures. But if someone sees a convulsion with our crowd of the developmentally disabled or the differently abled or the on the spectrum kids, what we usually see is that the convulsions are less often, and they often start around adolescence. And so a lot of us that are dealing with the young kids haven't seen a lot of them. Part of the reason I give this talk, though, is that I often see in puberty is when the epilepsy is first noticed, because that's when they start having convulsions. So it's going to be real important that I talk to you guys about the non-convulsive spouts. However, in case you're lucky enough to see a convulsion, let's go over what to do. The first thing is, don't panic. No panic is huge. The good news is it's not going to kill a child to have a 5-minute convulsion. Now, there is more and more interest in studying SUDEP, which is sudden unexplained death due to epilepsy. But SUDEP, part of the definition, is not during a convulsion. And so the good news is we're not talking about death by convulsion at all. And in children, you can have 30 minutes or more convulsion without expecting any kind of long-term brain damage or injury, which blows our mind, really. Part of the reason why we don't have to panic is if you see a real convulsion, one of the things that's happening is they're breathing involuntarily, because the chest is going in, and then it's going out, and then it's going in, and then it's going out. And so even though they're not breathing, so there's breathing going on. So now we know that during the convulsion, we're still breathing, it's just a different kind of breathing, and we're still having our heart pump, and so we're still getting enough blood flow to the brain and the heart, which of course are the most important things. If you ask a cardiologist, it's the heart. If you ask me, it's the brain, just the way it works. So we're not talking about immediate death. Now, I love doing talks for the kids. I'll go out to classrooms, especially to talk about Purple Day. Are you guys there purple day. And I say to all the kids, you guys show me your tongue. And they all go, I love that, kids just do it, right? And then I go, hey, can you swallow it? And they all go, no? Okay, right. Now, when you go home, talk to your parents about what you do with this convulsion. Okay, and if you put something in someone's mouth, and they're like, well, why? They said, oh, to prevent them from swallowing their tongue. Well, I've already set them up to go, they can't swallow their tongue. So, good news, you can't swallow your tongue. All right, so nothing in the mouth. I usually like to start with the positive behaviors. Like if I'm disciplining my child, I like to start do-over, let's try that again, instead of that was wrong, you're on a timeout, right? We do the do-over, but I do need to start with what not to do. Okay, how about some positive behaviors? Help them lie down. I think the floor is best because you can't fall off the floor. I saw a great Facebook post where it says, I'll always be there for you when you fall down. It said floor. I'm like, that's perfect. So put them on the floor. If you put them on a couch and they are moving, or if they start a partial seizure and they roll off the couch, then you're going to feel bad when you hit their head falling. So the floor is good. If you have a pillow, great. Put that under their head, no problem. And then you make sure that it's safe environment as far as like no glass. So has it ever happened that one of my patients had a seizure, fell down, broke a vase? Yeah, that's when I might pick them up and move them. They broke the vase, let's not worry about cleaning the vase, but let's move the person away from the environment. Okay, now, if there's any concern, you can roll them onto their side. The reason we talk about that is some people will vomit after. I personally have a real hard time holding someone who's seizing on their side. Brad knows, Brad's in the back of the camera, he's my practice manager, then it can be very difficult. We have one patient in our practice who had a prolonged seizure where it was this kind of seizure, and we're trying to get him on his side, and I'm like, guys, let it alone. If he starts vomiting, put him on his side. So the on your side is the official stance of everybody, except when you can't, in which case you just support them, and when it's over, you may want to leave them on their side, so that if they do throw up. If they do throw up, that doesn't mean they've got another separate illness. It often happens after a convulsion. And then you reassure them. You stay calm and you reassure. The good thing in medicine is there are very few real emergencies. And in medical school I learned that there's heart attack, there's having a seizure, having a baby, and I don't know, they said there's one other, I forget. And it's probably trauma or something. That's really not important. And the good news is having a baby is most of the time, it's like, that's what they taught us in med school. Most of the time you can just go and wait. Having a seizure, most of the time it is and wait. Most of the injuries are either from the initial falling down or from some bystander trying to throw something into someone's mouth. Or people starting to hold down someone. Oh, don't move that way. Okay, that may help you feel better because you're hoping it's going to end, but it really doesn't help to bruise the person. So we don't need to hold them down. So the big things, I'm going to redo this for a sec and make it all the positives now. Ooh, I like your eraser. You guys are quality. This is awesome. Okay. Okay. So if we see a convulsion, we're going to just go one more time, then I'll get back to the next step. If we see a convulsion, we put them onto the floor, we put nothing in their mouth, we put them on their side if we can, we breathe and we know that they're breathing, and we do not hold them down. If we can, we time it, and then we also reassure them when they wake up. Now, you guys are in a facility, you guys have malpractice insurance, so probably you've got to call 911 anyway. We always call 911 if it's a first seizure or if you don't know somebody. I don't know this person, but if someone has a medical alert bracelet or necklace and it says I'm epileptic and they had a 1-minute seizure and then they're waking up, you really don't have to call 911 unless you're in a place where you've got malpractice and you've got some kind of a policy. So I'm going to let you guys figure out if you guys have a policy here. And then, of course, if someone's injured, but if it's less than 5 minutes, and they're awakening, and let's say you're on the street and you found one of my patients, they might not be thrilled if you call 911 because they've got a huge copay every time they go to the ER. So after a while, the ER gets kind of tiring if you are not controlled on seizures. All right, so that's the first aid of what are you going to do. Now, we said there are other kinds of seizures. So let me first go into a convulsion is a seizure with movement. It's a seizure with movement. So that must mean there are seizures with no or very little movement. Now this is where it starts getting confusing for my patients and a lot of folks, because the neurologists have always talked about, not always, but for a long time, generalized and partial. But then I'm saying convulsion, convulsive or non-convulsive. So let me just make sure I'm a little bit clear, not that you guys need to get all too technical at all, but when you're witnessing something, I suggest you write down what you witness. If you write down that they have an absence spell, and that's happened to a lot of my patients, then a doctor might assume that an EEG has been done and they had a very particular kind of EEG pattern and that it looks generalized. That's not what we're trying to say. They stopped and stared. Let's keep it real. That's the way I like to focus on my notes. It'll say, stop and stare. I have a little phrase that comes up, interrupted activity to stare off, like a non-convulsive seizure. So what do I mean by this? Lots of my patients will be in the office. One of my favorite ones we got to see again yesterday. And when I first saw James, James had putty all the time. And he'd be stimming. And then he'd be stimming. Now, that's not for sure a seizure. When you see, you don't know, is he just halting in his stim? Did he get distracted? And then go back to stimming? It turned out for James those were all seizures. And when we got rid of the seizures, we then could get to James that was in there and train him. They don't have putty in the house anymore. Yesterday he was in the office, Mom went, I didn't even know he was able to do these things. Mom went, James, put away the dinosaurs. And James did a cartwheel or whatever, and then he went and put away the dinosaurs. I was blown away because James was so in his own world for so much of the day, so much rocking, so much, and then he was back. It was outrageous. So we can just call that a non-convulsive seizure, or that we suspect a non-convulsive seizure, so we're going to have it looked into. What if someone's in the car, they're watching TV, you're trying to get them therapy, and it's not their favorite day or topic, they're eating something they don't like, or someone's trying to get them to handle a sensation they don't like, and that's not a seizure for sure, okay? That's why I always ask parents, if they're doing a preferred activity, or if they're not getting into the lingo, they're doing something they want to do. I always ask, what's fun? Oh, well, what's really fun is blah, blah, blah. And, we knew this wasn't fun for James, so another example would be then, that if someone's going, Mom, can we eat out for dinner? Can we? What? And I've seen that in my neurotypical or my higher functioning kids where then Mom tells them, tonight we're going to eat out. And later, the kid goes, what's for dinner, Mom? Okay, well, I told you we're going to eat out. Doesn't that usually make you excited? And they're like, I know you never told me that. And then parents get upset because the kids aren't listening or because they're, you know what I mean? So there's a lot of ways that the stare can be difficult to see. But with the folks that are shutting down or staring, there's often a different look. There's a real kind of blankness, like lights are on and nobody's home. And so the difference between is pretty great in my mind. And I'm sure you guys, when you're working with someone, sometimes they've tuned out, and sometimes they are done. I don't want to think of it as oppositional. It's just, you've hit my spot. You've hit it. I'm done. And that's not a seizure. Okay, we doing all right? Okay. So that's a non-convulsive seizure. But what if someone's in the middle of doing... That's also a non-convulsive seizure. Or... That's also a non-convulsive seizure. I had one kid that would go up, ugly, ugly. She said the same word over and over. She always cocked her head the same way, and she always said something over and over. Well, that was great 15 years ago when I didn't know any autistic kids, and I was just a resident. Must be more than that now. But now, if I saw someone walking with their head cocked saying the same word over and over, I'd wonder if they're scripted. With that kid, we knew that wasn't scripting because, well, eventually knew, because then she had a convulsion and because she'd never done anything like that before. But that's the other one that's, I'm not trying to say everybody in the world is having seizures, but it's very difficult. And so the thing to look for is when the parents say, he's changed, or she's changed, or when we see a lot of these stares. And then the other question is, how often should we just screen people? And this is one of my arguments in life, because I'm just saying that they want every woman between this age and this age to get a pap smear. How often? But our kids with autism that have a 40% chance of getting epilepsy, oh, they don't need a screening until they have a convulsion. The literature says that 40% of kids, depending on who you read, 14 to 40% of kids who have autism have convulsions. The literature is based on kids that were diagnosed before 1975. And it says, oh, they start in puberty. Why does it start in puberty? Well, that's when the first convulsion was identified. But the literature really is saying 40 to 10% have epilepsy. And they're saying it starts in puberty because that's when the first convulsion was. So we know that is a very severe group because they were diagnosed before 1970. And that it's only diagnosed by convulsion. And now we're learning that there's a higher percent of kids who have epilepsy by EEG and by improvement when we treat them. But we still don't have any standards in the child neurology or the epilepsy world about screening them. So not 40% of women are going to have actual cancer. But 100% of women are supposed to get tested between these ages. So that's kind of one of my bets that I want to let you guys know. That's one of my biases. That's one thing I want to get out to the medical world also, is what are we thinking here about the concern that we could overtest? All right, now, the movement. We talked about this. Big hint, eyes are open. Almost never does someone have a full body convulsion and have eyes closed. Now, during the movement, you get head movements in the yes position. Get no position. No, it's not a seizure. Yes, it's a seizure. And so some kids will do repetitive behaviors that are non-epileptic. And so the no behaviors, and especially the no, okay, no, that's not a seizure. You guys already know that, but it's just something that not everyone articulates. And the other thing is the hands being opposite in their movement, less likely. And then seizure can be one part of the body. So if it's not the whole body, then it could be one part, but it's still generally going to be a flexion. So flexing my wrist, flexing my elbow, flexing and abducting at the shoulder, flexing my hips. So it's still generally a flexion, although sometimes it can be as small as just the wrist. And so a movement that can be the whole body, or that can be part of the body. And non-convulsive, that could be a stare, or a stare with some kind of action like walking. All right, so my definition of seizures, the way they look, is that working for everyone? Do we have any questions from the other group yet? Okay. Everyone awake? I'm not telling as many jokes as usual, so if I let you fade, really let me know. Now, your clients or patients may show up with diagnoses such as generalized or partial. The big important thing about generalized or partial is when I'm treating, some of the meds work better for generalized and some of the meds work better for partial. And when I'm deciding if they need, let's say, another MRI or they can have a brain tumor, if you have one part of the brain, so one part of the brain where all the seizures are coming from, I sure as heck better have the best quality MRI in the world to make sure that there's nothing there that can be taken out. How often do I find that? Well, I may not find it every day, but we had an example of this where a kid went to an ER with the first convulsion, and he had one more convulsion before he saw me. He only had like a 2-week wait or one. He only had a 2-week wait because he had to wait to get an approval to see me. But I see people very quickly. So in the 2 weeks from the first convulsion, he had a second. He had a CAT scan that showed an abnormality. And they told her, well, maybe he had an old stroke. I looked at it and I went, I don't think that's an old stroke. We got them up to UCLA. He got a MRI in the ER. The neurosurgeon came down and talked to him, explained that, yes, indeed, as I had thought, the kid's going to do a lot better when this is taken out. Let's continue the meds. And right after school was out, he got the tumor out. And Brad and I kept going, what happened to them? What happened to them? What happened to them? And Mom went, oh, I'm sorry, I forgot to come back. He's just doing so great. I'm sorry, your kid had brain surgery. Could you come back and tell me how he's doing? But the other side of that is, you're not coming back because you're so good? That's so cool. And so early identification of that is another biggie in my office, and I've seen some really great outcomes. Okay, so generalized, partial. If someone comes to me with those labels, I take them all with a grain of salt, and I want to see where the data came from. But when someone reports to me exactly what happened, love it. All right. Now, you guys see one, you guys decide, wow, I think these are little stairs. You're going to tell the parents something. That's great. Or you're going to say, I recommend. Whatever you guys can do that's within your purview is fine. And whatever the parents decide to do about where they go, all good. But I want them to not just see an adult neurologist if possible. And I know I'm also talking to other areas, so I don't know where I'm talking to. Let's just keep it that way. There are some places where there aren't that many pediatric neurologists. But even there, you could have a prolonged EEG, like an overnight, or at least a regular EEG. If it's normal, then you get prolonged. Why? What is that showing? Okay, so that's next. Okay. So then the next one is, how do I diagnose epilepsy? What happens between the time when you guys might notice it and when you come back, and how would it help the families to know about this? So I already brought up the clear tank, which is an EEG, but the bottom line is epilepsy is diagnosed clinically. And what I mean is the very same thing as developmental delay or autism. There isn't a single test. I mean, yeah, you can take out an ADOS, or you can do a CARS, or you can do this or that, but it's all observation and questioning and maybe interacting with the child. I mean, we hope, right? But it's not a, let me draw some blood, or let me hook you up to this, and then I'll say that you're autistic. And there's a lot of parents who want that, but I ain't got it yet. And I don't think you guys got it yet either. It is the same with epilepsy. We've got a lot of testing to do, but that's looking for the cause. Someone can have repeated little seizures. Let's say once every other week you see the person have a little stare, and mom and dad say, no, I really don't see it more than once every other week. Well then, let's say we do a standard 20-minute EEG, and they don't have anything epileptic. Brainwaves look normal. Everything's normal. What that means is there was nothing abnormal in the 20 minutes. Doesn't mean that there never will be or that there never was. It's like these video cameras that are on. If I don't go run to the potty while I'm getting videotaped, can we assume I never go to the bathroom? No. And I want to make it that plain and simple. The EEG is just about what happens while you're watching. Now, if we do a 40 to 60 minute EEG, is it much better than a 20 minute? Yeah. The prediction, the chance you're going to get something from these EEGs goes up as the time gets longer. And then if you do a 24 to 48 hour EEG, your chance goes up to 40 to 50% that you'll get something. And that all depends, of course, if someone has 3 spells every day, the chance that you're going to at least be able to get a spell, look at the EEG and the brainwaves during the spell and say, gosh, during that spell, the brainwaves look so normal. And then you have to look a little deeper sometimes, but at least if we catch a couple, that's better. And we get this really important thing that America undervalues called sleep. And we all know that a ton of our kids, and probably a ton of ourselves, are not getting enough sleep. We seem to have it, and then it's gone. We get it, we seem to have it, and then it's gone. Another patient we saw just yesterday was one of the really happy stories. He came in having had 3 convulsions. On my first visit, I got this history. Child was adopted, had some interesting biologic family history. So an at-risk child who really was not making eye contact with me and didn't really care about social norms and didn't read the room and was sort of all about me. And so my first impression when I walked in the room was either this is a really angry person about being here right now, or if this is the pattern of his behavior, I got to figure out, is this a pervasive disorder where he doesn't know how to be social, or he doesn't care? By the end of the first visit, I said, okay, the child has epilepsy and autism, and we've got to work on this. Interestingly, when we did do a regular EEG, the regular EEG showed abnormal, but it didn't show the whole picture. The overnight EEG showed that he was in a continuous spike wave during slow wave sleep, whatever. Bottom line is, every time he started getting into the deeper sleep, he would be seizing so much that his brain wasn't working at all. We saw him after the definitive treatment for that, which it's not a common syndrome, believe me. And yesterday he was sitting on Mom and Dad's lap. He was going, hey Dad, what are we going to do for dinner? I was used to, Dad, I don't talk. And it wasn't just a little Prozac dust on this kid. This was an amazingly different kid. And I went, I'm sorry, I think I was premature with calling him autistic. And when I did go back to, you're supposed to start before you're 3, I thought I got symptoms that started before he was 3. But this was an amazing turnaround from getting rid of the sleep problem. So now when he's sleeping, he's like a whole new person. And I try to remind parents that when they had their child and they were in that first 6 weeks wasn't so bad, but then between 8 weeks and like 24 weeks of life, they got tired because this kid was up a lot at night. And I'm like, can you imagine living that way every day? It would add up and it would be harder and harder. And then you would start feeling every hair on your arm and that would bug you, and then you'd feel the tags would be even worse. And then the less sleep you get and the more, it's kind of like living with migraines and shoes that are too tight. You're just not so good anymore. And you're like, oh, okay. So then we try and bring it down, and once we get them sleep, it's huge. So to diagnose epilepsy, it's still done by what I get as a story, and especially lovely if I can get the video of it, which I love on these phones. People can video their kids. Totally love that. And we do an EEG. In my office, I don't really bother with the 40 to 60 minute one, because if it's abnormal, I'm still going to wonder how often is this going on, and what does their sleep look like? And if it's normal, I'm still going to go, didn't tell me anything, and get a prolonged EEG. The standard of care when I was trained, though, is you could do up to 7 40 to 60 minute EEGs. You'd have then a 95% chance of finding the abnormality if it's there. Meaning that still 5% of the time, you have to go on your clinical suspicion. So you wouldn't do these tests and then they say they're not epileptic. Occasionally, we would admit people to the hospital and we're getting so concerned that they're really not epileptic that we'll do like a 7-day admission or something. But I hardly ever saw that when I was trained. So now we have an advantage that we can go a little farther than just saying, let's do 7 of these. And also a lot of my kids, by the time you go to the effort of getting 20 electrodes on their hair, you might as well wrap it up and have them wear it for a day or 2, because you got the hardest part done. And so if you just hold them still for 40 minutes, that's not going to work, because number one, this kind of movement kind of ruins the EEG. And if I send them home with it, maybe they will move most of the time, but at least they'll get some amount of time where they're not moving, they're sitting there watching TV or something, or they're doing something. I love doing it where they're coming for ABA or speech or whatever, and then the therapist can go, right then, I saw it, right then. I love that. And I think that's very, very helpful. By the time you hook them up, why the heck not get the whole thing? So this is one part. Now again, diagnosing epilepsy, not just with this. It's a bedside diagnosis. But once I believe they've got epilepsy, just about everybody gets an MRI. And the kids that can't hold still get sedated, and it's safe and it's fine. And I have the parents bring the disc to me and we look at it together. Because nothing's the same as looking at the pictures. All right, so we get an EEG and we get an MRI. And let's say the MRI is okay and I don't find anything. But let me answer a question, Seth. I get MRIs. How often on my kids that have epilepsy and autism do I find something? And I would say about 5% of the time I'll find sinusitis, and about half of those really need treatment. And I've had people that had to go to an ENT and that everything got a lot better when their sinuses got better. And then I would say about, 2-3% of the time we find something in the brain. And some of those are really big differences. So there's one kid that is like the most friendly, the most social, the most sweet, developmentally delayed kid. And I mean, we had a photo shoot, Purple Day, and he was like, everybody, group hug! He's running around with the diagnosis of autism. He's got an abnormal formation of his brain that I can see on the MRI. And so the other thing that I try and do, just so you guys know, and I try and encourage everyone else to do, is when you are looking, look for everything else also. Is what, just so you guys know what that is. And so it's but I can't go back and say, by the way, he doesn't have autism. That hardly ever works if someone else makes the diagnosis. Still, he's so cute. He's so cute. Should I see that guy? Okay. So those are the things that often happen once they get to see me. Let's go on from there. Okay. So then the question I often get is, if convulsions do not equal death, I love this one, right? So convulsions aren't going to kill you. And if they don't fall down with their non-convulsive seizure, why don't we just leave it alone? I haven't heard this one in a while, but we had one, I'm sorry, yesterday was a really big day. I'm not sorry, it's great. It keeps talks going when you can use real things. But we had this nurse whose kid had repeated stop and stares. He'd be on the swing, and then you'd see he's not there and the swing's still going. He's like ready to fall off. Like, oh, he needs more vestibular training. I'm like, no, that wasn't, I'm sure it wasn't a therapist saying that. I think mom was saying, he needs more vestibular training or whatever. So the kid repeatedly had stares, got sent over to me, got an EEG, it's epileptic, but there's fear of meds, of medications. And to this mother's credit, it's not that she had already done lots and lots and lots of injectables or supplements or invasive other therapies that just weren't Western med, and then didn't want meds. She didn't want anything other than PT and OT and speech, which is really good places to start. But when I really do wonder about this is when people are like, I won't do meds, but they come in with a bucket of their supplements. So the other thing I do tell people is that you guys may or may not want like this. Water can kill you. How is this related? Well, if you drink enough water fast enough, you really can die. Someone did it a couple years ago. There was some promotion. Who can drink 4 gallons or whatever? And she died because she drank it really fast. I don't know how many beer bongs she had been doing, but before then she got really good at drinking. Okay, so you can drink enough water to kill you, but does that mean water is bad? Well, no. We kind of need water. So at the right amount, oops, okay, I'm going to try that again. At the right amount, water is good. Now, I don't know anyone for whom they don't need water. Does that mean that everybody should have a lot of water? No. The amount of water you need is different for everybody. Okay. Now what about B12? Does everybody need B12? Yeah, we all know we're getting it in our food. Do some people only B12 shots? Yes. Do I know who those are? No, not my area. Will a B12 shot cause harm? Hurts, costs money. So I do that kind of analysis with people. The downside, let's say, of a B12 shot is how long does it take to get in your car and drive there? How long does it take to get the shot, to wait, to da-da-da-da? How much does it cost? Because we're going to look at the pain, the time that the child's not getting doing something else, and the cost, the money that could go somewhere else. But the time that the parent could be doing something else too. So when I'm looking at a therapy, I look at those things as well as does it have physical side effects. Well, what about my meds? Well, if you do need to have epilepsy treated, then meds are the best option. And here's the fun part that I like. When there's side effects of the treatment, no matter what the treatment is, it's not usually, well, you have to do this for 3 months. And it's often really bad at first. It's usually, we're looking for someone to pay more attention, to be more alert, to wake up in the morning refreshed, or to not zone out, to remember what they've learned, to feel more comfortable in their own skin so that they're less sensory, to not have convulsions, to growing out of their epilepsy. And we're looking for not someone who's drugged out. So the biggest fear that I hear from parents are, well, they're going to drug my kid's going to look zony. And the biggest thing I see afterwards is, my kid is so much less zoned out. So that's just something that if you guys hear about, I don't know why I'm going on and on, except that I had that patient yesterday that was, it's been like 1.5 years, and I'm ready to go, should I call DCSF? Anyway, okay, so the treatment is not just medicine, yay? All right, and so, one more time. So, treatments, yay. I like to go with the families about doing everything to support the child and to support brain health. And brain health, you guys already know a lot about it. Brain health is even better. Little dyslexic. Not a lot. At least I'm not cutting kidneys out of anyone and getting that confused. So, brain health, I have been really shocked by how effective some diets are. And when you're talking to me about diet, we're talking closer to the earth, less processed. We're talking if you're going to have dairy and meats, which I have no problem with having, let's get grass-fed, or let's get local, or let's get eggs and chickens at scratch. I don't make everybody do it, but these are some of my suggestions. And I go for, with each time someone has carbs, let's get them some fat and some protein, which is a philosophy that is under the low glycemic index diet. And the whole, whoops, forgot index. The whole idea of when I start treatment is start with those things that are good for you anyway. So if everyone in this room decided they were going to get the low glycemic index hambo and start eating that way, it wouldn't harm any one of you. And it would probably be good for all of us. Now, most of you guys are thinner than I am, so it's not just about losing weight, although I did once lose a lot of weight by just eating well. But it's also about feeling more alert and getting the important fats to our brain. I can tell you one of my personal, my husband's a psychologist, a neuropsychologist, and a nutrition guy. And between he and I, we're pretty sure that the American Heart Association has told us for so long to eat low fat that that would help us not get cholesterol plaques in our hearts, that people are deficient of their essential brain-making fats. And then when you go and try and make babies, when you don't have enough of the stuff that makes brains, I don't think it all works quite right as well as it could if we had the good fats in us. And so I really do talk to a lot of my patients about what is a good fat. And the good fats are especially those that are in nuts. I know they're allergic. I know. Avocado, coconut, and there are lots of others. But the bad fats basically are the things from corn that are saturated and that have the omega-6s and 9s, and I can go into it forever. But the bottom line is, if we wanted to learn about the low glycemic index diet, that's different than diet for brain health, although they're all intermingled. And if you wanted my favorite place for information, I'm going to write it here, hold on, is .epilepsy.com. Best website because it's overseen, not all the blogs, but the real articles are all overseen by doctors. And it's not just doctors that are like, well, we don't believe in complementary and alternative medicine, because we've got whole books on that as well. And that's one of my favorite lectures actually is CAM anyway. So if you go on to here, there is Epilepsy 101, and there's also treatments. And under treatments, they go into meds and they go into diet. And just so you guys know, there's 3 dietary treatments for epilepsy. One, you think GFCF is hard, you should try the ketogenic diet. That's like 80% of your calories from fat. It has to be weighed. It's calorie restricted and fluid restricted. It's not for everybody. I don't do it in the office. And then there's an Atkins for seizures. And it's got happily its own website, atkinsforseizures.com. And that I do talk to some people about it. I've had some people really do it. They really did it. And it was one that was pre-surgical. And in that case, it didn't work, but the surgery did, and she's been seizure-free. And she also stopped coming for a while. And I'm like, Chica, are you doing junior lifeguards next year? You gotta come see me, because I gotta sign off on it. Okay. But she's doing junior lifeguards next year. She had to go a year without, just 1 year. But then we got her anyway. Okay. And then there's the low GI. So when families come to you and say, or if they mention, someone said, I've got epilepsy, you can say, gosh, please look at epilepsy.com. It's amazing. You can warn them. It can take 3 weeks to try and read all the content. Because when I first started, about 3 years ago when I started in private practice, I went on a vacation with my family. This is what I planned to do on my vacation, was get to know all the content in epilepsy.com. Not making me a good mother at that point. I gave up anyway. But during the 6-hour drive there and back, I tried, and there was no way. There's a lot of content. So there's plenty of stuff that they want to learn, and then they can learn about diet, and you guys could too if you wanted to. And then you can also let them know that there are complementary things. So if someone comes in freaking out, and I know no matter whether you're supposed to be doing speech, OT, ABA, half of your time, no, maybe a quarter is counseling the mom every time, or the dad. And I'm just thinking, because that's kind of what it feels like for me when I bring my kids somewhere. So it's kind of about me. I've got 3. So the other place to go, maybe a little self-serving, is www.askdrstein.com, and we've got resources. And under our resource guides, we've got one about how to get an IEP, and we've got one that was a public health written document about what is epilepsy, and it's on a really good level. It's, you have over this many billion cells in your brain, and they all use electricity to talk to each other. It's really, really basic, and then it goes into what are the different kinds of seizures, and what should people do, and how do you deal with it, and what are the meds. So it starts at the right level for a lot of people. So we've got a couple resources, and we've got the resource about the diet, and diet was my #1 therapy. Does that mean it's going to work without meds? No. So even though diet is #1, #2 is going to be meds. #3, or we can make #2 this one, other lifestyle choices. And I kind of like this a little bit. I want to spend just a minute here because at UC Irvine, we've got a professor of psychiatry who is also a neuroscience PhD. So he's got an MD for psychiatry and a neuroscience PhD, and I think he's also an anthropologist or something. And he's a master meditator, and he works with the Susan Samueli Center for complementary and alternative medicine, all these interesting things. He's written books about spirituality, but then he lectures to the psychiatry fellows. Nice, I know, right? Tender loving care? Okay. And he talks about which things really have data to support that they are as good or better than Prozac or Zoloft or other drugs for depression or anxiety. Now, I don't know about you, but I see a bunch of kids with anxiety. When things have to be a certain way, when tags can't be on the clothes, the sensory issues lead to the anxieties. Or the anxieties are, I already know that there's a shark in the ocean, so Daddy, don't go to the beach. Yeah, that was yesterday again. Yesterday was a big day. So these anxiety things, we know that there are things that can help that are therapeutic lifestyle choices. And he gave 10, all of which have Western science studies, head-to-head versus drug. And each one of them was better than the drug. So what do we have? We've got diet. Okay, I already did that one. We've got adequate and restorative sleep. Well, I kind of already did that one. We've got, wow, there's 10 and I'm already going, give me a second here. Okay, so we've got relationships. Even if you don't want to see anyone that day, often being dragged somewhere and being with people does lighten the mood a little bit. Or when I went to high holiday services and I had a migraine and I looked over and I saw this old man with Parkinson's who could hardly hold his prayer book, but he stood up and I was sitting because I felt I'm too sick to be up, down, up, down, up, down. And then I look at this guy who's standing up and sitting, I'm like, okay, I think I can handle this one. And I stood up with everyone else. I didn't want to go out, but I felt better after I did, even though I had to do stuff. So people, being with people, being in groups, that goes with community involvement. And so even if we're not just talking about kids that can be so easily overstimulated that going to Disneyland is like right out, Chuck E. Cheese right out, bowling alley out, there's still some chances for community involvement. And for the rest of us, when we go and we do a volunteer time, oh yeah, that's the other one, volunteer, or we go to church and we've got a group that we're involved with, we feel happier and we have less anxiety. Touch is important, we all know it. And yet, what's happened in Western medicine with everything becoming sterile, one thing I like about places like this is when the walls are curved and when there's lots of stuff places, you know it's going to be more relaxed. It's welcoming. And also you guys probably, with permission, you know, hey, how are you today? And you offer your hand and you touch the person. And getting touch is hugely therapeutic. What I say to teenagers is, pet your dog. Teenagers aren't going to hold hands, and they're not ready for necking yet. At least mine isn't. And so, you know, they won't cuddle with me anymore. Pet the dog, you know, do something. Go do dancing with a friend where, you know, you're going to have to touch people, but it's not like touch. Anyway, touch is huge. And then spirituality, which, you know, little kids, it's kind of hard to do the spirituality thing. You know, you can bring them the water, but you can't make them drink on that one. But what I do sometimes tell the families to try and do to have the kids learn to be grounded, especially the boys, because boys, it's hard to just go down deep, breathe. I mean, my son, like, he'll laugh at me, basically. But if they're doing jiu-jitsu, did I say it right? Jiu-jitsu? What? Okay, I can't say it. Okay, that's like my disability, I can't say things. So, but they can learn how to feel the earth. I was talking to a friend of mine who is an atheist. I know, how did I get on to atheism, right? I'm talking about seizures, I'll get there. I'm probably, I don't even know how much longer I have. 5 minutes? Okay, I'll wrap it up. But he goes, look, you know, how can you be spiritual if you're an atheist? I'm like, well, what do you do to make yourself a better person or to get in touch with who you are? With the boys, we can teach them to get in touch with the earth. Feel your feet on the ground. Take a minute and feel that that ground's not going anywhere. Just feel that. And then we can go on. And so that can be the beginning of that part of healing anxiety. If the ground isn't going to go anywhere, let's start finding that part of spirituality. And then there is activity, exercise, and time outside. And the thing that we do have a jiu-jitsu teacher who will teach the kids outside. So they're getting exercise, spirituality, and outside. Bing! 3 for 1. So we talk about therapeutic lifestyle choices, and part of that is having time for play. And play isn't the same as exercise, but I'll put that under relaxation, self-time, which was supposed to be on the list, so now I probably made it 11, but it's really 10. So that's part of the balance that I'm sure you guys are all trying to lifestyle choices, their therapies, their physical disorders, whether it be epilepsy or something else, and not missing the opportunity to improve their quality of life by helping them, even if it means a Western medicine. And then the other part is I strongly encourage people to, when they have children with convulsions, to carry something to stop the convulsion. And that does a couple different things. One is helps you stop the convulsions, so you don't have to call 911, but it gives the family a sense of control. There's huge benefits to internal locus of control. Am I just married to a psychologist, or was I one? Yeah, I majored in psychology. Okay, but if you give someone something you can do, if you give them a plan, just like I'm hoping all you guys give them homework every week, and I tell people, when you meet your speech therapist, ask them for homework. And some people look at me, homework, well, it's speech. You want them to only work on their speech 1 hour a week? 2 hours a week? How about every day all the time? And same with the OT or the ABA. What's your homework? What's our plan this week? So, where was I just at before the plan and homework? Control. So when someone, thank you. She's paying attention. I love that. So when someone is known to have convulsions, encourage them to get something that they have that can be used if there's a convulsion, both so that they don't have to call 911 every time, and so that they feel they've got a plan and in control. All right, questions? What do you say, epilepsy? More than just the physical convulsions. Oh wow, I didn't do that. Okay. This was the, what is epilepsy as opposed to what is a seizure disorder? Good. Sorry. Wow, that's important. Okay. Epilepsy, oh, it's purple, happy, is a condition that leads to unprovoked seizures. And the natural history of epilepsy is that if over time you had no seizures, no seizures, no seizures, 1 seizure, 2 seizures, 3 seizures, you are going to start having more seizures if it becomes untreated. So epilepsy is a progressive neurologic disease or disorder that can be controlled or put in remission. And full remission is what we like to use instead of cure. With therapy, and without therapy, will worsen not just the tendency to have seizures, but your brain's function. And seizures are the manifestation of epilepsy. I know it's a little circular, but we talked about different kinds of seizures. But a seizure is the manifestation of epilepsy, or we can get a little technical, high voltage burst of electrical energy that's rhythmic for at least 3 seconds. But I know I see seizures that are less than 2 seconds, and they're still seizures, and they're still interrupting things. So the seizure we can see on an EEG usually, and the epilepsy is the clinical diagnosis of a seizure disorder, but it's where there's going to continue to be unprovoked seizures if it's not treated. Good question. Sorry I didn't get there. Did I answer it enough? Yeah. Okay, questions? Yes?
On EEG, how do you tell the difference between seizure activity and STIM?
Oh, totally can. On the EEG, how do I tell the difference between a stim and a seizure? Well, we have not just all the leads on the head, but we have some EKG leads, unless the kids won't take those. Part of what happens with movement is that you can see the electrical movement of, or the electrical activity. And so when the EKG lead goes crazy, I know they're moving like nuts. And then whenever they're, like if they're eating, I see this rhythmic muscle artifact. And so I know they're chewing or eating. When they're jumping on a trampoline, I see the whole EEG go like this a bit. So muscle artifact shows up really well. But then the question is, what if their seizure is, right? Then I change my filter settings to get rid of the muscle artifact and see what's underneath, if possible. Or I look at the video, which is one reason it's so good to have a video. Because if we've got normal background, and then I get a couple spikes, which are abnormal electrical graphic activity, but not really the seizure yet, but you get a couple things that you're like, oh, here it comes, and then you have all this movement artifact, and you look at it and you're like, yeah, that looks like a seizure. Then I know for sure that's a seizure when I put the video and the EEG together. So the real combination message is we are trained, anyone who reads that right. And then we tell people, can you please not, try to get them to not scratch their head, or maybe one person that kept doing this. So we give them a lot of hints as to how to get them to not really screw it up so that I can't see anything also. But that's the basics, is experience and setting it up so you can read muscle. And then if there's a video, it's so helpful. What else? Yes?
What about uncontrolled or random laughter? Would that be seizure activity?
Yes, but I've gotten into so much trouble. The question was, how about random laughter? Could that be a seizure? I gotta tell you, there was one week where I had 3 different kids who had this repeated laughter. And on one of the 3, I'm so upset that I ever even mentioned it, because I didn't have it confirmed by EEG. And the mother said, yeah, there's 2 different kinds of laughter. There's the I'm having a good time laughter, and there's the ha 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 ha, the mirthless laughter. Don't like mirthless laughter. And the question was, is the mirthless laughter a stim? Is it something was funny and that's my other laugh? Is it a seizure? What is it? And she emailed us, we had 116 seizures yesterday. And we're like, really? You're taking your time and watching them laugh all day? Okay, so we don't want to encourage parents to write down every time they have a weird laugh. There are gelastic seizures, which are laughter seizures, but they're normally a mirthless laughter, and it's very different than their normal. So if my normal laugh is and that, anyway, sometimes it's more like a cackle, but we'll take that one right now, okay? And instead, I stop what I'm doing while I'm in the middle of ha, 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 ha. Well, of course you go, that is freaky, red world. You know, I mean, you kind of go, whoa, what's that? That's a gelastic seizure. Now, gelastic seizures often also come with a lot of abnormal activity. And again, when I started practicing, before there was so much autism out there, probably everyone I saw with gelastic seizures, which would be 2 in 10 years when I was at Kaiser, I sent them to the nation's best, and there's a whole long story about it, but probably they would have been labeled autistic because they have a lot of behaviors that are quite interesting. Because to have gelastic seizures, you basically have a tumor right behind your eyeballs and by the pituitary. So anyway, the answer is yes, but don't bring it up unless you're pretty darn sure. Okay, and also they tend to waken from sleep with the mirthless laughter. Now, that's as opposed to some other kids, like Angelman's will wake from sleep with laughter, and it'll last an hour. A seizure doesn't last an hour. So I don't need you guys to get all the intricacies down, but if you can really overdo it with that laughter thing, so save me from too much of that. What else? Questions? Yes?
I've got a question from Matt in Hawaii regarding the TLC that you spoke about earlier. They're wanting to know if there is a way to access more resources or info from the gentleman who talked about
Perfect,
that.
cool. There was a question about the TLCs, and let me, the author is Roger Walsh, MD, PhD, and he has the original paper published in Psychology Today. And I think it's about a year old. I think it's 2011. But I don't remember the title of it. I don't remember if it was called Therapeutic Lifestyle Choices for Depression and Anxiety. I'm not sure if that was it. We've asked Roger to write a book. He's written a lot of other books. There might be a book coming out. Who knows? But that's the name of the author. Psychology Today. I think I blogged on it, but I just haven't blogged in like a year or so. Probably on my website at askdrstein.com. If you go through, you'll find an old blog about it. I should probably make a new one and bring it up to the top and cite the article, but I'm not going to promise I'll do it. Someone else can do it. Yeah, what else? Yes?
What do you say to parents who may have not had a short 20-minute EEG some years ago, help them think about this thing again, or put in their doctor and then open to no longer 24-hour EEG? How would they?
Yeah, it's pretty tough sometimes because often there is this idea that, well, there was one EEG and it was fine. And so sometimes the family does need to be the one work with a doctor and say, you know, I've been reading to some really reputable sites about how epilepsy can be missed on a plain EEG, and I see these spells, and they happen not that often. I was wondering if we can do an overnight. And if they say no, then how about a 4-hour? I'll tell you the hint here. A 4-hour EEG is reimbursed at the same rate as a 40-minute EEG. So no one really wants to do a 4-hour. You're going to make more if you do overnight or if you do 40 minutes than if you do a 4-hour. But it's very reasonable for a mother to ask for a 4-hour. And so then it might be upgraded. I'm just saying. Not everywhere is set up to do them. There are some places, most places it's done in the hospital, and not every kid can hold still in a bed also. So we do here, I'm kind of excited that we have, and I don't know, why am I so uncomfortable with this shameless self-promotion, but the bottom line is, it's a service that's great for folks because we have, Lonnie used to work in a center with the autistic kids. We now have an ABA therapist who became an EEG tech, who puts the leads on kids' heads. We've got Brad, who sits on their face, no, who holds them down, who supports them during these, and we get them wrapped up. We have little wires that we put cable ties on the wires and then put it into a little backpack. We now have Angry Birds backpacks, or we have whatever the backpack is that everyone's like, you know, in the day it was Pokemon. You guys remember the Pokemon, and it was, you know, Angry Birds. We've got whatever the backpacks are, and then if you keep this on, you get to keep the backpack. And it's wireless to the webcam, where they can have all their video going and getting synced to the tablet. And then it can be taken out and looked at. And if there are spells, the other great part about it is when mom and dad push the button or write in the diary, you know, saw him stare, saw him this, saw him that, and they push the button, then I can bring them into the room and show them the video and say, you know what, you were right. Every time you pushed was a seizure. And look at what this other thing is that he does that's also a seizure. Or I can say, none of the things you pushed were seizures, but look at this other thing. Or I can say, you're amazing, but those are, teach them what it is they're seeing. And he doesn't have anything during the day, but look at the sleep, or you know what I mean? And the times that it's been most rewarding is when I can sit with the mother, and I've had that mother that sat there, and she pushed the button like 50 times. And there was another 10 or 12 seizures on that one kid in the day. So it's been an amazing teaching tool, both to say, you know, those behaviors aren't and those behaviors are, and to show them that is by linking it synchronized in time. But how can I help them get that? I don't know. And how will they do it when they're in the hospital and they keep having someone on the intercom going, can you tell him not to touch his head? Tell him to sit down. He's not on camera. Put him back on camera. Wait, he's touching his head again. And then you have the mother in the hall, been there for this, saying to the tech, whether I'm a good mother or not is not up for question. Whether my kids stay is what's up for question. So you have to go into these things with, we're going to get the best we can. And not everyone can be done as an outpatient. It's just not in anybody, not everyone can pay out of pocket, and not everyone has it in their network. So you do what you can. If someone does get an outpatient EEG by any service anywhere, please ask to have it continuous. There's one service that they'll get a couple minutes and they'll just keep doing that, but we don't see what's in between. And that same service can do it as a continuous. So we want continuous EEG, even if that means, well, then I can't do 3 days, I can only do 1 day. Okay, we'll do a day, and then I'll come back. And then you can, whatever you need to do, and we'll do the second day. But continuous is very helpful, because I did the others for about 1.5 years, and then I learned, wow, my pickup rate is huge with continuous compared to intermittent. So continuous, in or outpatient, best you can do, even if you only get 5 hours of great recording, better than nothing, better than 20 minutes, and hopefully getting some sleep in there. What else? What?
Oh, yeah.
There's no age limit on doing EEGs.
They don't pull on the little tiny ones that you can't explain what's going on.
We've had 2 people pull them off. One, neurotypical except febrile seizures, mom didn't care. wasn't a big issue. And the other one, we all applauded that she kept it on for 8 hours. But typically, even our most difficult sensory kids, we've had great success. It's really all about the parents. We've sometimes used no-no boards, and with this one little kid, Miguel, that mom was so good. We told him, every time he goes for his head, put the no-no boards on for 2 minutes. No, no touch, and then you take them off. And when they don't touch, you applaud. And then, if they start pulling again, no touch, 4 times, you're done. And I found that these don't just help me make a diagnosis. Some parents come back empowered because they said, we didn't know we could get our child to comply with anything for 2 days like this. But by the second day, they weren't going anywhere without the backpack. And I've had parents that came back, and I'm like, wow, he's so much better. This again was yesterday. Yesterday was such a big day. But they came back going, he's so much better. And I'm like, well, what did you do? Well, we started speech yesterday, and we started OT 4 days ago, and we changed his diet 2 weeks ago, and we got the EEG 2 weeks ago. It's probably all the diet. Okay, I'm good with that. But I think part of it was they learned they were in control. And they said now the kids are going to sleep on time, they're eating what we're telling them to eat, they know we're in control, we know we're in control. Wow, what a neat lesson. So yeah, they keep it on. They keep it on. And the two that didn't, it's very rare. Also, if medicine was back when none of us had insurance and you pay cash, then you really keep it on. I'm not opting for that, I'm just saying. The more you pay for it, the more compliance you're going to get. And I find that that's an interesting phenomenon in our world. And I am in network with a lot of people, but I'm just saying, it's an interesting phenomenon. And also, the more effective it is. All right, what else? Yes?
Just wanted to clarify, so the next stage is to get an MRI, which is the activity of the MRI,
It doesn't have to be a tumor. You can have an abnormal growth that's not going to get worse over time, so something that's benign. You can have a developmental abnormally formed brain, which helps me tell them about their future. If it's not typically formed in a certain way, then I can go, oh, we better check their pituitary. If they have the laughing seizures and they have this tumor right here, I know they need to go either to Australia or to the only person in the United States that does that surgery, Phoenix. Or if they have another thing, I might go, ooh, that could be tuberous sclerosis, and this is the only drug that will work well for that. Or tuberous sclerosis, we better also check these other body symptoms. When that looks like neurofibromatosis, I've got to check your blood pressure every year. You've got to get an ultrasound of your kidneys and your heart. So it's part of finding out what's the overriding thing. I mean, if I look at autism as a spectrum, there are some people that are vanilla. If I'm looking at desserts, we've got some vanilla ice cream. But I've got some green tea sorbet. And I've got some baked Alaska. And I've got some things I've never heard about. And so I want to figure out, are these vanilla? And there's no tumor, there's nothing wrong with what the brain looks like, and there's some seizures and some autism, and we're going to try and get both of those better? Or is this someone who has green tea sorbet? They've got both autism and epilepsy because they've got neurofibromatosis. And then we can also test the family. And instead of saying the recurrence rate is this or this, let's look at these other things. And so it gives me a way to do the whole care of the whole person, depending on what I find. And yes, finding a tumor or finding a mass, I talk to them about then checking if you're a candidate to perform at the Olympics. I say the Olympic tryouts can be looking for a surgical candidacy. People are like, don't mention surgery, but what I try and say is we're not going to do any surgery. I want to see if you qualify for the team so that if we ever need you to be on that team, you can. And the outcome when they get the surgery up at UCLA for peds epilepsy is amazing because they're not going to take someone that they can't help. Because they don't want it on their record books either. Oh, my success rate's 50%. No, their success rate's way higher. You want someone with, when it comes to this, who say, I'm not going to do this if it's going to be a triple play. I'm looking for a home run. I may tolerate a triple play, but I ain't getting a double play or a single. You know what I'm saying? And so everyone goes for surgery. Anything else? All right, if you guys want any more information, you can always call the office. If you have a family member that's really scared about something, I'm sure Brad will talk to them for a little bit. If you guys have questions about what it's like to be the parent, Brad's child has been seizure-free for over 3 years. And he's my practice manager, and that's how I got so lucky to work with him. And I didn't cure, but I got him on a path that worked out real well for both of us. And so I want to thank Brad for hooking me up with you guys and for working with me every day. Purple Day. Please you guys go to purpleday.com. This year, .org. This year we're going to Disneyland. We're trying to get 10,000 people to wear purple with us. Brad will send you guys information about when and where, but we're trying to get people from all over. Whoever they get the ticket from will get some of the ticket money. Some will go to Purple Day and the rest will go to Disney to get us in the door. So we're really excited. We're going to make it big.